Welcome to the Medical Report podcast, where we bring health to your ears. We are your hosts, Zinzele, Olu, and I am Anita. Our podcast hopes to help the community learn more about health, but we do have a disclaimer that all medical advice shared here is not an adequate means to diagnose or treat you. We recommend that you seek medical attention from your healthcare provider if you want more guidance on your health. If anyone in the audience has questions, please feel free to leave your questions in the comments and we'll answer it in our Q&A segment later in the show. If you're watching this after our live show ends, feel free to ask your questions in the comments as well. Also, be sure to like and share this video. We want to feel the love. And I hope everyone's been doing well this week, right? So,
Yeah.
Zinzele and Olu, how are you guys feeling?
I'm good. How are you?
I'm good.
I'm doing good.
I see you're glowing as usual.
Always. Isn't she?
What can I say?
Almost like you might be expecting.
We would never. Look, this is a running joke we have right now. You're not going to do this to me, okay? Maybe one day, just not now. Maybe one day.
Okay.
All right, so today we're talking about hospice care. Hospice care is something that we may have to make a decision about for ourselves or family members. So today we wanted to give you more information about what to expect and opinion and options that are available. I can't talk today. Hospice care is a healthcare service that is geared towards continued treatment of the patient with a life-limiting illness until their death occurs naturally. Hospice is appropriate for patients that no longer want to pursue aggressive treatments that combat an active disease, like a patient with cancer that no longer wants to pursue chemotherapy. Instead, the patient chooses to focus on their quality of life with the time they have remaining. Hospice care is a collaborative effort with input from the patient, family, and many different medical disciplines. The hospice care team is typically made up of the medical director, which is usually a doctor or can also be facilitated with other providers like NPs and PAs. An RN case manager, social worker, chaplain, and certified nurse assistant, and many other disciplines like physical therapy. The decision to begin palliative and hospice care is unique to each patient. So today we have two guest speakers that work with hospice care to share their experience and expertise with us. So can we bring on our guests? Hi, guys.
Hey.
Hi. So today we have Miss Latisha, who is a social worker. She frequently works on hospice care teams in skilled nursing facilities. And we also have Miss India. She is a physical therapist that also works with hospice care patients in a home health setting, correct?
Yes.
All righty. So Miss Latisha, my first question is for you. What patient or who would qualify for hospice?
So if in a skilled facility, which is a nursing home, we would generally look at a patient who would fit the criteria for someone who on hospice. There are usually 5 ways to determine if someone is appropriate for hospice. There's age, there's a disease process, there is weight loss, there's help me out here.
Yeah, there can be a lot of different things to look at. I mean, it could even just be if they're just deeming them medically, if they have something going on, or if the family sees that they're declining in some way, and it seems a little more appropriate for that to be put in place. Yeah. So, does health insurance cover hospice care?
Health insurance does cover it. Medicare covers it in a skilled facility. But it can also cover it in a home setting.
Okay. And are there other insurances besides Medicare that may cover hospice?
Well, Medi-Cal will cover.
Okay.
The Blue Cross is your regular insurance.
Yeah.
In a nursing home setting, Medicare usually covers.
Mm-hmm.
It covers the hospice part, and Medi-Cal will cover what's called a room and board. So it pays for the stay here for your room.
Okay. And then is there what should families expect when hospice is started for their family member in a skilled nursing facility or a nursing home?
You would expect a meeting to disclose that hospice at this time would be appropriate. We would have a meeting with the interdisciplinary team. It would be with the nurse, social services, a medical director, just to kind of go over that plan of care. We would do and initiate a hospice team to come in and do a consultation to kind of go over what the expectation would be with end of life, depending on their circumstances and health.
Okay. Yeah.
I have a question. How does hospice care in a nursing home differ from regular care in a nursing home?
So with hospice, it doesn't really change much, but hospice bringing in a team into a facility or into your home. Well, you're talking about a facility. So you're bringing in, it's double the team. So it's 2 social workers. You've got, you got 2, the nurses that are together. This thing keeps popping up. You have a chaplain that comes in to meet your spiritual needs. We have care conferences like to disclose that. But it's an additional team to help with the staff that's already here. So just to make sure that your needs are being met.
More hands and more love.
Yeah.
Yeah.
So
Hospice is so important. Like when you're at end of life, the more your attention that you're getting for your needs to be met.
Right.
people have a tendency to think hospice just means I'm dying. It's not that way.
No, my experience and what I've seen in the last few years is the perception that the community has on what hospice really is. They think of hospice and they think, oh, my family member, I'm dying in this week or tomorrow.
Right.
And that's not the case. Usually hospice has a few barriers that you would look at. You know, does a person going in and out of the hospital frequently? Do they have an imminent disease that's in place? Imminent meaning that there's no cure or anything that you can do to reverse that. Mm-hmm. And so that's just a really good, topic to discuss. But
yeah, I think that I think in general people have this idea. I mean, especially in skilled nursing facilities, like I've seen patients go on hospice and then they start improving and getting better. I've had patients that have had weight loss and we can't understand why. They've already tried all these medications like Remeron to improve their appetite, or changes in their diets and increasing protein and all this other stuff. And then they get put on hospice. They get certain, there's a lot of different things that hospice offers for them. And then they start improving. And then after a while, they're like, they don't even meet hospice criteria anymore. And they come off of it.
Yeah.
They graduate.
Yeah.
Which is great.
Yeah.
But not all patients get to do that.
Mm-hmm.
Yeah. From a speech pathology perspective, it's like, people don't realize that when they have swallowing problems, they'll say, and they're on hospice, they get the freedom to choose their diet. You no longer have to have a speech pathologist telling you, I'm sorry, your swallowing is not functioning well, so you have to be on a puree texture. On hospice, you can say, I don't want that. I'm out. I want mechanical soft. I want regular, which is, just softer foods or regular foods. And so I tell people sometimes hospice might be the way to go when you want more power. That's how I see hospice as giving you the power to make decisions. I understand there's some limitations, but you also have the ability to say, no, I don't want that. I want what I want.
Mm-hmm.
Yeah.
It's my end of life.
Question for Zenzeli then. So even if they can aspirate, they can still say...
Absolutely. They have the choice to aspirate, meaning the food goes into their lungs, which could cause a possible pneumonia that they could die from. Absolutely. They have the choice to do that.
I've had a patient in skilled facilities before where she was just like, she had really bad, she was on it wasn't a thin liquid, it was a honey nectar, that thickened liquid. And she was on puree. She was on she could not eat solid food. And it really upset her. She really wanted to just have a burger.
Well, what we look at is we look at quality of life.
Yeah.
So the risk that you're taking. So when I go in and I talk to someone, they say, I don't want that pureed food. I don't want to eat that crap. And I say, no problem. Just understand the risk. As long as you are cognitively aware enough to understand the risk, you take those risks. It's your choice.
Right. So India, who on your experience has qualified for home health hospice? Like, what's the best patient that would be more home health versus in a skilled facility?
Home health, usually someone it's kind of interchangeable, honestly. You might have a
Mm-hmm.
bed-bound patient in a nursing home. I've had bed-bound patients at home.
Yeah.
So as long as you have a hospital bed, if that's their functioning status, people at the nursing home walk. And I've also had hospice patients at home who walk around. Some do end up getting off and getting better and
Mm-hmm.
getting off of hospice altogether. Some don't. But the functional status, it's still a wide range.
Yeah, it seems like it's almost like resources to the patient. So it's kind of
Right.
what it kind of depends on. Do they have
Yep.
family and support at home that can help take care of them in addition to that, or do they need skilled or nursing home help with those additional staff members like nursing and all that other stuff?
Yep.
Okay.
Yeah. So a lot of patients at home, they do have the either, like you said, the family support or caregivers paid help versus being at a nursing home. So it really depends. I've been in some skilled facilities where the caregiver is able to still come and be with that patient.
Mhm.
So it's just such a variety.
Mm-hmm.
So,
And
sorry to interrupt, but so as a PT, what do some of the goals look like? Because I know what they would look like for a regular home health patient or a patient in a nursing home.
Right.
But someone that's kind of like, transitioning, are you shooting for the stars or like a regular patient?
We really don't have goals. We really just improve their quality of life. So treatments might include massage, edema massage, or just massage for comfort, depending on their level of activity. If they can walk, we'll just walk. But there really are no goals. I always say, this is hospice. It's really based on how you feel. So if I come here and, you're in bed, we can do exercises in bed. I can make you more comfortable, positioning to prevent bed sores. It's just, like I said, such a variety depending on what they want and also just their overall physical state. But we
So,
really don't work towards goals. Once you really start reaching goals and going from the wheelchair to walking to the stairs, then they might
not
get you off
qualified.
of hospice. Yeah.
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 Just depending. Yeah.
What is it like personally working with people on hospice as opposed to a regular patient?
I actually really like it. I don't know if that's strange, but I do like talking to people who are near death, who are just I just like to I like to see what their perspective is currently and what their plans are for their families. Sometimes it can be pretty fulfilling. So depending on how they are, yeah, I actually enjoy it.
Good.
So
That's awesome.
yeah, yeah.
Well, I'm glad we have people that want to be there that are there.
Exactly.
Oh
It's
yeah.
necessary. Yeah.
I definitely
So-
enjoy it.
okay. And then, so Latisha, what resources are available for families that start hospice?
What resources to stop?
So for families outside of just the patient, so do hospice services offer any like supportive care or anything like that for families during that that
They
time?
do. Once your loved one has been accepted onto the hospice care team, they have a program where they will reach out to you during that transition to help you get through that. And even after the time that your loved one passes away, up to 1 year, they still extend that service to you to help with the grievance process. Grievance doesn't start, when the patient is on hospice, or it starts before that. So they help during that transition to make sure that the families and the resident and everybody who's involved is all on the same page and help with that.
How could a family member know when someone is ready for hospice?
I personally, when I start to see clients that are in and out of the hospital due to their medical reasons or clinical, they have a decline and they're in and out, and they don't seem to be getting better, but seem to be getting worse. At that point, I think it's time for a conversation to take place, and look at the big picture and find out what's going on. Is this something that's going to be a continuance? Is it something that's going to be resolved? And if not, let's look at more of a comfort, quality of life, and hospice may be appropriate at that time.
Yeah, that's exactly what I always experience as well. So can the patient switch to another hospice agency if they don't like the one they have?
They sure can. When they're admitted or accepted into hospice, and it doesn't matter if it's 1 day or if it's 2 months, if you are not satisfied with the service that is being provided to you, there is a form. It's called a revocation. You're basically revoking hospice with them, and you're able to request a different hospice agency. Usually without any relapse. If there's a medical doctor that's on board in a skilled facility, or if you're at home, the primary doctor, there won't be any overlap. You'll still be able to receive the care and the comfort and medications if that's needed during that transition.
Yeah, that sounds good.
I have a question. Why would you want to switch hospice agencies? What does a bad hospice agency look like?
Well,
India's got some answers too. But we'll do.
Well,
Go ahead.
I was going to say I've experienced a patient who he's Jewish, and the hospice agency he was with just didn't meet certain religious needs that he had. So that was one reason. And they do ask you what your religion is, what are your preferences, and I guess all of that goes in your advanced directives. But that was one reason that I experienced.
What was it exactly? Are you able to share? What was it? What was the request that he was making?
Unfortunately, I never got the chance to ask him what it was. I did continue to see him and do therapy with him, and I did want to ask him, but he actually stopped his services because I think he became more and more ill. So I did not know. I didn't get a chance, but I was curious as to what do they do that this agency doesn't do. So
yeah, I mean that's good to know culturally, like how when we're dealing with different religions, what it is exactly we need to making sure that we're cognizant of. Yeah,
right.
So important that we're putting that together when we're talking with the team. What the patient wants religiously, like Latisha was saying, even chaplains are available and things like that. So
right.
So if a chaplain doesn't, I'm sorry.
Oh no, I'm sorry. I was going to say it was interesting to learn that there is an actual Jewish hospice agency that he ended up switching to. So,
oh, okay. Well, it's probably preference. Yeah.
Yeah.
What were you saying, Latisha?
Yeah, I kind of forgot. My mind is just going all kind of places right now. Because hospice is so important, especially when it comes to end of life. A lot of families or even themselves think when they think of hospice, it's like, oh, I'm dying right away. We don't want you on hospice the week that you are actively passing. 6 months or less is what they usually say. But if you have an illness and develop a relationship with a hospice team. That way they can know what your wishes are and your desires during that time, so that when you are imminent and you're not able to be vocal and you don't have your capacity to express what you want, it's there. They know you, and so they know exactly what to put in place for you. It makes it really difficult when someone is imminent and they're passing. You're quickly trying to get someone on hospice so they could be comfortable to manage their pain. And they pass away 2 days or 3 days later, or even 7 days later. It's really rough.
What makes it easier for you as a social worker? Like whenever someone, I guess maybe would an advanced directive or a will in place be more helpful whenever that it gets to that point? If patients wait too long and then they're not able to make those decisions on their own?
An advanced healthcare directive is super important. No one is too young or too old to have an advanced healthcare directive. I really think that it's good to put what you want on paper, because you never know. Tomorrow's never promised. And so if you weren't able to speak tomorrow, who would know what you wanted?
Right. Yeah, I agree with that.
Going into a care facility, communicating with your social worker if there's a chance, that your loved one or yourself is going to become imminent. They have advanced health care directives in their office. They're able to reach out to a local ombudsman and come in and get that signed and filled out so that there's a plan of care in place.
Yeah. Right. It's very important that families take that time to spend with their family members and talk about it. It's a hard topic. No one wants to talk about it. But it's important because sometimes it causes a lot of family issues.
Definitely.
Especially when family members aren't able to tell people what they really want. And people are sitting there assuming, well, this is what I think they'd want. And then people get into fights. And I've seen that happen in hospice care. The patient becomes unable to make their own decision. And then there's two children that don't agree on how their mother should be taken care of. And so then it becomes this big thing.
How can you prevent that? How can you prevent to be in that type of situation?
Talking about it, having a plan in place. Yeah. That's how you make it preventable.
Exactly. That's the only thing you can do. I know my grandmother had a plan. She had it down to the T. Like she was very descriptive of what she wanted, what funeral home that she wanted, the wishes that she wanted to happen, if she wanted to be a DNR or not. In the hospital, in the instance that something were to happen.
What's a DNR?
Do not resuscitate. So DNR, that's another scary thing people don't want to talk about, right?
Yeah, seriously.
People think if I'm put on DNR status, that means that they won't take care of me anymore.
Right.
I hear
and
that.
And that's not true.
No.
It just means that you don't want someone giving you compressions if your heart were to stop.
That's it.
Doing all of that. There's several like do not intubate and do not resuscitate. So some people don't want to have ventilators. They say if I stop breathing, do not put a tube in my mouth. That's what do not intubate means. Do not resuscitate is no life-saving measures. If it comes to my heart stops, then you need to let me go.
Now you can set that up at whatever age you want, right? That's not you just talk to your primary care doctor, right?
Yeah, right.
And you can set that up. You don't have to wait until you're ill to make a decision like that, correct?
Exactly.
Okay.
Yeah. And that also makes it easier for your family because people will fight about that. They're like, no, we have to keep trying.
That's what I see. That to me is the sad part. That's what I see is that they will keep someone intubated for so long. And then what I try to express to them, at least from my side, my field, is that when you're intubated that long, your ability to speak, your ability to eat, all of these things are impacted the longer you're on it. So you have to just not consider that the person is there, but what will their life be like once it's been removed?
Their cognitive status. People have to think about their cognitive status. When they wake up from that ventilator and intubation, will they be that person that you knew before?
Exactly.
Or what will their life be like after?
But people just want to hold on to their family members so long. It's like, as long as that person's alive, everything is okay. But it may not be okay for that person.
Mm-hmm.
Yeah.
So that advance directive could stop all that, correct?
Mm-hmm. Correct.
Yeah.
I've been in the room for someone who was in cardiac arrest with the DNR, and it's weird. You want to jump in there and like this guy's dying in front of us. Like, somebody do something, but everybody's like, nope. We just stand there all weird and looking at each other as this guy transitions.
Just hold their hand.
It's their wish. Yeah.
That is the hardest part.
And there are some times where, especially elderly patients, they're so frail. If you think about doing compressions on them, I've seen ribs broken.
Yeah.
And they puncture things because compressions, that straight on your rib cage.
Absolutely.
So, it's all long-term things that we must think about, but they are difficult decisions to make for sure. No one wants to think about these things. All right, audience, now is the time for questions. If you have any questions, we do also want to remind you, we cannot diagnose or treat you here on this podcast, but we are open to questions.
There's one. Does hospice provide care 24 hours a day?
When you're in a care facility, yes. We have 24-hour care that is provided. If it is at home, it is not 24-hour care. The care that's provided in the in-home setting is really dependent on the family, or if you're hiring help to come into the home.
Okay. Will insurance pay for help in the home?
If there's Medicaid in place, you can get an IHSS worker that can come in. Often in my experience, I've seen either families or members of the congregation or community step in to help families with hospice at home.
How hard is it to get an IHSS worker to come help you?
Right now, because we're in this pandemic, it is taking a lot longer for applications to go through. It could be it used to be 30 to like 40 days that you could get your application processed, but I'm starting to see it's a little bit longer now, more like a 90-day process.
Yeah. Next question. Grandma can't move too well. She sees a physical therapist once a week for an hour, but won't do anything on her own when the physical therapist isn't there. Should she be doing things on her own? India, we'll leave this one for you.
Yes. Yes. Well, is grandma a hospice patient? No.
He didn't specify that, but.
Oh yeah, well, definitely. We're only there a couple times a week. So I always tell my patients, you should be doing your home exercise programs twice a day. So, yes.
So when physical therapy comes in, you guys teach them things to do, and you also teach them things they can do on their own to continue when you're not there.
Yeah,
so those
because
things,
like I said, we're there a couple times a week and we won't be there forever, unfortunately. So
India, how do you encourage someone to do more when they are hurting and you hear what they say, I'm in pain and it's hard, and you hear all the excuses but real reasons too,
Right. It is hard. I do listen, we do talk. Physical therapy isn't all just putting weights on them and exercising. We do have a lot of conversations, and just I like to let my patients know, you don't have to stay in pain. A lot of people don't.
Right.
I know some people just really don't like pain medication, but I'm like, take your pain medication before I come, and so you can do more. You don't be afraid to, if it's prescribed to you and your doctor's saying it's safe. Don't be afraid to take the pain away. A lot of people just don't want to take anything. So it can be hard to motivate people. But like I said, sometimes my sessions are just education and just talking to them and understanding where they're coming from and what we can do just to make everything better and make our session as productive as possible.
Olu, what do you do to motivate your physical therapy patients?
Crack the whip. No.
I mean, we have our own PT on our,
No,
codes.
I mean, like she said, like some sessions are just. Sometimes I feel like I'm a psychiatrist or psychologist. You're just sitting there talking to people about, why is it you don't want to do anything, and maybe you just have a session or two, just telling them the benefits of physical therapy and why you have to explain why we're doing this, why we're doing that. A lot of kind of hand holding a little bit and telling them this is the goal that we're trying to reach. But it's weird because I've never done hospice before, so that's why I wouldn't. I don't know. I don't know if I'd be the PT for hospice because I'd be shooting for a goal. Like,
Right. You're like, let's get better.
What's the end
Range
result?
of motion would be your goal.
yeah, but it sounds more
You
like
would,
restorative care, like in a nursing home.
Yeah.
right.
Like you're just there to maintain, sort of, kind of.
You would
Yes.
know how to turn it on and off, especially depending on the patient. You would turn it off if he's frail and he's on hospice and he's just not feeling it that day. You would know.
Yeah, I mean we're gonna do something, but
Right.
yeah.
I think we may have covered this question earlier, but Latisha, one of them says, my grandmother's 90 and has failing health. She is at hospice care at this point, but needs so much assistance. At what point does one determine that hospice care is required?
We did cover that question earlier. You would want to look at her as a whole person and her medical, diagnosis, her overall health condition, and determine, if hospice would be appropriate. At this time, I would say, communicate with your healthcare professional and just let them know what you're seeing in the home setting and allow your primary doctor to go ahead and move forward with either care at home or in a facility if that's needed, or hired help to help you out.
I think in general, just think about if you feel your grandmother isn't functioning at the level that she used to, if you find that she's not eating like she used to, if she's losing weight, if she is just not, maybe wanting to participate in her normal day-to-day activities, those are things that you'd want to bring forward to your primary care doctor. Next question. Chris says, how long will the insurance pay for it? Is 6 months the max?
6 months is not the max. So usually when someone has been accepted with hospice, whether that be in a home or in a facility setting, at 6 months, it's when the hospice physician then is doing an evaluation to see whether or not the client still requires hospice care. And if they do, then they recertify for another 6 months. So it's just a 6 months review, and your insurance does cover that.
So I have a question. So will the insurance keep paying and paying if the doctor keeps recertifying every 6 months? Like,
Yes.
Right.
even if it goes like 5
Yep.
years down the road, 10 years?
Well, I wouldn't
If
say
they're on it
5
that
years.
long, do they really need
Yeah,
it?
right. Are they
I think
really
my question is, will the
Right.
insurance eventually be like, what are you doing? What are you paying for here? Like, what are we paying for? They're
Yeah.
going to speak up at some point,
Sometimes,
right?
yeah, sometimes there's just clients that really, really hang on. Like there's a need, like they're just really stable. Even though they're not eating, like I sometimes I don't understand it, and it's not my place to, but we've had patients that have been on hospice for like a year and a half, and it's been appropriate.
Mm-hmm.
So it just depends on the patient's need. It's on a case by case basis. Not everybody's situation is the same.
Okay.
Chris says, can you pre-plan hospice care for grandmom or granddad?
You can. I mean, it's a discussion that's part of the advanced healthcare directive, you discuss at what point in your life do you want to be placed on hospice? That is definitely something that you can talk about. And when the time is appropriate, contact your physician to get that in place.
Teresa said, I love hospice. Such a blessing. So much support for the PT, physical therapists, and families. I learned so much as a case manager. Just wanted to say, great topic.
Thanks for tuning in, Tessa. I think that's all the questions we have. So we hope you'll tune. Oh, wait, there's one more.
There's one more. When should the decision be taken out of the person's hands?
Well, that can't really be done unless the medical professional deems that patient incapable of making their own decisions. So usually there's some type of evaluation that's done, maybe if they have dementia or Alzheimer's, to basically evaluate their cognitive status and ability to make those decisions for their own health. So we just want to be sure that whatever decision is made for that patient, it's the safest one and one that can be thought about thoroughly before made.
And just on a side note to that, that's why when I go in to do cognitive evaluations on patients, they don't realize how serious it is, how important it is. So what I'll do is I'll let them know and I'll say, hey guys, this is an evaluation to determine whether you are able to make decisions. Because if you just go in and say, I want to check your thinking skills,
right?
They'll I don't want to do that, or they'll just give me half of what they could possibly give me. And you have to really make it clear, like after this, whatever I write and give to the physician, the family members will take it from here.
Right. Exactly.
So, yeah.
All right. So we hope that you'll tune in with us again in 2 weeks and connect with us on our business pages on social media. If you're watching after our live session has ended, you can still leave your questions in the comments and we'll be sure to answer them. If you have any suggestions on a healthcare topic you would like us to cover, please send us a DM and we may consider that. We hope that you stay well until next time. We'll see you.
Bye.
Thanks for again.
Thank you.
Latisha. Thanks, India.